Welcome to Dental Scholars, where we share useful information related to dentistry and oral health.
The trigeminal nerve is a fifth cranial nerve that transmits both motor and sensory impulses. It distributes along the facial region. It has three branches, namely the Ophthalmic Branch, the Maxillary Branch, and the Mandibular Branch. Neuralgia is a pain that is experienced in the tissues along with the distribution of the nerve. Trigeminal neuralgia. Trigeminal neuralgia is an abrupt, sharp, severe, lancinating, paroxysmal, short-lasting, unilateral type of orofacial pain. It follows the anatomical distribution of the fifth cranial nerve and almost always exhibits the trigger zone. Trigger zones. Trigger zones are the zones that, if stimulated, initiate pain. Some trigger zones associated with trigeminal neuralgia are those of the nose, cheeks, around eyes, gums, lips, or even teeth. The tongue is rarely involved as a trigger zone. The pain is usually noticed with facial spasms, aka tic, therefore also called tic douloureux. The pain lasts for a few seconds to minutes. The other names for trigeminal neuralgia are Fothergill's disease and trifacial neuralgia. What are the causes of trigeminal neuralgia? The cause of this disease is unknown. It is usually idiopathic, aka idiopathic trigeminal neuralgia or classical trigeminal neuralgia, but some underlying conditions also provoke trigeminal neuralgia. The trigeminal neuralgia due to underlying pathosis is called symptomatic trigeminal neuralgia. The underlying causes of trigeminal neuralgia may be compression of trigeminal roots by tumors or vascular abnormalities, lesions within the cranium like aneurysms, tumors, and abnormal vessels, various granulomatous and non-granulomatous infections, including trigeminal nerve, Ratner's jawbone cavities, post-herpetic and post-traumatic neuralgia, multiple sclerosis, and so on. Talking about the clinical features of trigeminal neuralgia, TN occurs in older individuals, usually above 35 years of age, having female predilection in the ratio of 3:2. It commonly affects the right side of the face compared to the left side in the proportion of 1.7:1. The incidence rate of TN is significantly less, as it is seen in about 4 in 100,000 people. Clinical presentation. The clinical presentation of trigeminal neuralgia are shearing, piercing, shooting, stabbing, or lancinating pain on one side of the face, usually initiated when the patient touches superficial trigger points of the face. Wind, air puff, or washing the face can also initiate the pain. One patient usually has one trigger zone. Pain may also resemble a sharp toothache, so patients may give the history of multiple extractions of root canal treatments done on the respective side of the jaw, but no reduction of symptoms. Pain lasts for a few seconds to several minutes, and it disappears promptly. Pain rarely crosses the midline. It's usually confined to one part of one division of the trigeminal nerve, but may occasionally spread to an adjacent division or rarely involve all three divisions. The location of the pain is stereotypical and identical. The pain usually occurs during the waking hours, early in the morning, but the pain is absent during sleep. Trigger factors like noise, light, and stress may also initiate pain. On examination, the patient often lacks oral or personal hygiene, which results in unwashed and unshaved areas due to the pain. The location of trigger points depends on which division of the trigeminal nerve is involved. The trigger zone on V1 usually lies over the supraorbital ridge of the effective size. Similarly, the points of V2 are located on the skin of the upper lip, a la nasilar cheek, or upper gingiva, whereas on V3 is the most commonly involved branch. Trigger points are seen over the lower lip, teeth, or gingiva of the lower jaw. The paroxysms of pain occur in cycles, each lasting for weeks or months, and with time, the cycle appears closer and closer. With each attack, the pain seems more intense and unbearable. In extreme cases, the patients will have a motionless face, the frozen or mask-like face. Two attack-related phenomena are particular to TN, namely A. Latency and B. Refractory period. Latency is the short period of time between stimulation of the trigger area and pain onset, whereas refractory period is the period that occurs following an attack, and during this time, pain may not be initiated. It is important to note that there is no sensory loss of the affected area. Pre-trigeminal neuralgia. In pre-trigeminal neuralgia, there is a dull, continuous pain in one of the jaws. It mimics odontogenic or dental pain. As this progresses, the pre-trigeminal neuralgia becomes typical TN. The pre-trigeminal neuralgia is highly responsive to carbamazepine therapy. A case. A 40-year-old female came to dental OPD with the chief complaint of pain in the right upper jaw region for 1 month. The pain was acute on the onset, severe, sharp, shooting in nature, short-lasting, about a minute, abrupt, and radiated towards the temporal region on the right side. The pain usually occurred early in the morning and during brushing her teeth and did not occur during night. The pain did not respond to over-the-counter painkillers. The patient gave the history of RCT done on the upper right first molar tooth 3 months back. Nothing relevant was found on intraoral clinical diagnostic examination and dental radiographs. On extraoral examination, the pain was elicited when the clinician palpated near the ala of the nose on the right side. What could be the provisional diagnosis? Also, suggest further investigations and treatment plans?